everyone. Thank you for joining today's 2023 MIPS Call for Quality and Cost Measures Overview webinar. This presentation will be followed by a Q&A session, and attendees will have an opportunity to ask questions. To note, you can either submit written questions via the Q&A box, or you can raise your hand to ask a question via the webinar audio. A recording of the webinar and accompanying slides from today's presentation will be shared on the Quality Payment Program webinar library within 1 to 2 weeks. Now I will turn it over to Lisa Marie Gomez at CMS to begin.
Thank you. I want to thank everyone for joining today's webinar. During the webinar, we will review the requirements, timelines, and expectations for submitting quality and cost measures for consideration in the merit-based incentive payment system, also referred to as MIPS. On an annual basis, we review the inventory of MIPS measures, which includes submitted measures for consideration. We look for measures that are robust and meet clinical topic priorities and needs identified under MIPS. At the end of today's presentation, we will provide an opportunity for you to ask questions. Next slide, please. Now I'm going to introduce Vinithya Mayer. Vinithya is a Deputy Director for the Division of Quality Management, and she will be discussing the CMS National Strategic Priorities. Vinithya?
Thank you, Lisa Marie. Good afternoon. Thank you for joining today's webinar. Today, I will be reviewing the CMS strategic goals and priorities for quality measurement across all CMS programs. CMS will set and raise the bar for a resilient, high-value healthcare system that promotes quality outcomes, safety, equity, and accessibility for all individuals, especially for people in historically underserved and under-resourced communities. Our national quality strategy goals focus on health equity, improving quality outcomes with improved patient safety, and engagement with patients and communities to provide them information to make the best health choices. CMS is also striving to transform quality measurement into digital measures and achieve all payer quality data collection. We are committed to promote innovation in care and resiliency of the healthcare system in order to improve quality of care and reduce clinician burden. Promoting standardized approaches to quality improvement with alignment of measurement across CMS programs will also help reduce clinician burden and drive quality improvement across settings. Next slide, please. Looking at the future direction of MIPS in quality payment program, we have begun the transition from traditional MIPS to MIPS value pathways, or MVPs, which are available for reporting beginning with the 2023 performance period. Subgroup reporting will be an option for MVPs, which will provide options to clinicians in multi-specialty groups to report quality measures most meaningful to their scope of care. As mentioned in the previous slide, CMS is transitioning to digital measures using standardized elements in the US CDI and is interested in the implementation of more patient-reported outcome-based measures to further drive quality of care and patient health outcomes. Additional CMS considerations when evaluating measures for inclusion in a CMS program include reflection of areas of high impact that could lead to improvements in care for all individuals and encompass patients' care goals. Emphasis should be placed on measures that promote safety and have no unintended consequences and no impact on health equity, especially for rural communities. CMS is looking to align measures across various CMS programs and federal programs where possible. Next slide, please. So please take a moment to review the disclaimer statement on this slide, which covers this presentation. And I would like to turn this presentation to Laurel Myers.
Thank you, Vinitha. This is Laurel Meyer with PIMS team. Looking at the rest of the agenda for today, we will be reviewing the annual call for measures process and requirements, considerations when evaluating measures, the transition to MVPs, and some resources. We will end the day with a question and answer session. Next slide, please. To kick things off, we will provide a quick overview of the MIPS annual call for measures. Next slide, please. The annual call for quality measures process asks interested parties, including clinicians, professional and medical societies, researchers, consumer groups, to submit quality measures for consideration in the quality performance category for MIPS. Recommendations from these interested parties are part of our rigorous quality measure selection process, since they will likely submit what is meaningful and applicable to clinicians. Next slide, please. The MIPS annual call for cost measures process provides interested parties with an opportunity to identify and submit measures for CMS to consider for use in the cost performance category. This annual call for cost measures process was established through the calendar year 2022 physician fee schedule final rule, and provides interested parties with guidance about measurement, priorities, and requirements. This is the second year of the 2023 is the second year of the process for the MIPS annual call for cost measures. Next slide, please. I'm going to go over an introduction for the annual call for measures. The Meaningful Measures 2.0 framework serves as a guide to evaluate each measure for inclusion on the MUC list to ensure the selection of measures pursues and aligns with the agency's priorities. CMS encourages interested parties review the annually published MUC program-specific needs and priorities document when developing measures and submitting them for consideration of inclusion on the MUC list. The CMS quality measurement strategy is continuing to drive towards patient-centered, value-based care through the development, selection, and implementation of measurement that includes accelerating the transition to digital measures, promoting the use of all-payer data, increasing the alignment of measures, and representing the patient voice. Next slide, please. We wanted to provide a high-level call for measures timeline for a typical year in which the annual call for measures opens in January. Within the March and April timeframe, we hold educational webinars, with the annual call for measures coming then to a close in May. We use July and August to review the measure candidates and evaluate how the measure aligns with the CMS's needs and priorities. We will also dive into that topic a little bit more specifically in the upcoming slides. By September, we provide feedback to the submitters as the MUC list enters the CMS HHS clearance process. Typically, the MUC list is published no later than December 1st to gear up for the consensus-based entity, or CBE, meetings that occur in December and January. The CBE recommendations are then published in February. The CBE process is to provide recommendations on the measures to HHS with the overall goal to maintain transparency and encourage public engagement. CMS reviews the CBE final recommendations, and the rulemaking team will make final determinations which MUC list measures will move forward to be considered for the MIPS program. Measures that are finalized during rulemaking will be implemented and available for reporting the following year. Next slide, please. Some overall expectations. In order to be considered as a MIPS measure, a submitter is required to submit a few different items. Of course, we will need the measure information along with a peer-reviewed journal article template for MIPS quality measures. All measures need to be fully developed and tested at the clinician level and feasible at the time of submission to the call for measures. There may be additional outreach to gain clarity if the team has questions as the measure is evaluated. As a reminder, measure submissions are entered into the CMS MUC Entry Review Information Tool, or MERIT, for the 2023 call for measures. Moving on to after the measure submission period, if a candidate measure is placed on the MUC list, the submitter is expected to attend CBE meetings that were just referenced in the timeline. This allows interested parties to ask questions, provide feedback, and fully understand the measure prior to engaging in the voting process. Finally, if the measure is proposed and finalized, the measure steward would maintain the measure through the annual revision process. This process ensures the measure aligns with the current clinical guidelines. The coding is updated as there are annual revisions to the ICD-10 and CPT codes, et cetera. We do promote coordinating measure changes across collection types for quality measures, governing bodies, and other CMS programs, as this will contribute to reducing reporting burden. Additionally, we request the attendance of the measure stewards on the measure steward meeting hosted by CMS as scheduled. Next slide, please. There's some additional measure maintenance expectations for those measure stewards of electronic clinical quality measures, or ECQMs. During the annual update cycle, measure stewards are expected to participate as well as understand and apply standards, including QDM, CQL, and FHIR, make technical changes, and support responses to interested parties' questions while adhering to the timeline and processes outlined for each annual update. Please note this is a distinct update cycle and begins earlier than for other quality measure collection types. I will now turn it over to Colleen Jeffrey to talk about measure requirements. Next slide. Thank you.
Thank you, Laura. This is Colleen. I also work on the PIMS team. So we're going to move on to discussing some of the measure requirements. Next slide. So CMS does look for measures that are fully developed, as this is highly preferred for the program. When looking at the merit submission, the critical data elements should have patient encounter level tested, noted as yes. The completion of reliability testing at the accountable entity level should also be noted as yes. And this is in the 2023 MUC data template. And the completion of empiric validity testing at the accountable entity level noted as yes as well. Please note that while face validity, as noted in Word 47 of the 2023 MUC data template in Word, does not meet fully developed criteria, however, it will be temporarily accepted for new quality measures. Next slide. For those measures based on survey data or patient-reported tools, it would be expected that the survey or tool has also been tested, noted as yes in row 62 of the 2023 MUC data template in Word. Measures based on assessment tools must have completed patient encounter level testing for each critical data element in addition to testing of the assessment tool itself, with no changes to the tool needed. Please do note, if you wish to proceed with a submission for a measure that is not considered fully developed, we would need you to provide additional details regarding development status in CMS merit. Next slide. As I had mentioned, for a measure to be considered, it must be tested at the clinician level, which is the entity level for MIPS at the time of submission. This includes reliability testing to ensure the measure can reproduce results. This can be demonstrated by signal to noise ratio. We also require that a measure is valid and accurately represents the concept and achieves its intended use. We would direct you to the CMS MMS Hub for additional guidance on testing and have included the link within the resources section of the slide deck, as well as in the next slide. Next slide, please. So for ECQMs within MIPS, there are a few additional requirements. Measure output in the health quality measure format using the ECQM standard. The data collection mechanism must be able to transmit and receive requirements as identified in MIPS regulation. The specification has MAT output to include HQMS human readable files, value sets, and Bonnie test cases showing 100% passing and 100% coverage. Feasibility utilizing the CBE feasibility scorecard, such as NQF's feasibility scorecard, and reliability and validity testing completed that meets the definition of fully developed measure. Please see additional measure resources for ECQM related questions. Next slide, please.
Looking ahead, we wanted to keep this on your radar. So looking into FHIR, Fast Healthcare Interoperability Resources, a data interoperability standard developed by HL7 International for the purposes of exchanging healthcare information electronically. FHIR combines a simple workframe of building blocks or data elements with the latest web technology to standardize the way healthcare data is represented and shared. It is flexible enough to be used across a variety of EHR and other healthcare exchange platforms, as well as accommodate complex healthcare data needs. How would this impact the ECQM? Instead of using QDM data elements and QRDA reporting, FHIR data model and FHIR reporting requirements will be used for presenting and reporting ECQM data. The FHIR standard has the potential to reduce overall burden on measure developers and implementers by providing faster real-time access to quality data, align data exchange standards with clinical data support initiatives, and automate both EHR data retrieval and quality data submission. So some exciting things happening in the world of ECQMs. Next slide, please. Looking at MVP considerations, which require linking of performance categories. Since the 2020 annual call for quality and cost measures process, submitters were required to link their MIPS quality measures to existing and related cost measures and improvement activities as applicable and feasible for the purposes of MIPS value pathways or MVPs. Submitters are required to provide a rationale as to how they believe their measure correlates to other performance category measures and activities as part of the call for measures process. This will aid in the development of robust and cohesive MVPs. Submitters may also link the measure to a finalized MVP. We will discuss the transition to MVPs in the next couple of slides. Next slide, please. Next slide. So the transition to MIPS value pathways. This year has marked the start of MVP availability, and there are currently 12 MVPs that are finalized and available for submission. The goal of MVPs is to create more cohesive participation experience by connecting activities and measures, resulting in a more value-focused program and reduced selection burden. So, how do we take that into consideration during the call for measures? We will look to see if the measure candidate aligns with the MVP framework by looking to see how it complements the improvement activity and cost measures. This is an important link moving forward, as I said, as we transition to MVPs. MVPs are a subset of measures and activities established through rulemaking. The MIPS program aims to drive value through collection, assessment, and public reporting of data that informs and rewards the delivery of high-value care. Within MIPS, we intend to pay for healthcare services in a way that drives value by linking performance on cost, quality, and the patient's experience of care. Next slide. Next slide. All right. Next, let's talk about measure evaluation and considerations. Next slide, please. Each year, CMS assesses the quality measure inventory and identifies specialties and clinical conditions that are not widely represented within the MIPS measure inventory. We would request measures that support these measurement gaps. From our initial review, we are seeking measures applicable to the specialties and conditions listed on your screen. CMS really seeks to have the patient voice represented in quality, whether it be from a patient-reported outcome or a shared decision-making measure. Next slide, please. In addition to specialties and clinical conditions on the previous slide, CMS assesses the quality measure inventory for alignment with priorities and focus areas. These include increasing the number of outcome and digital measures in the inventory, looking for measures that represent care coordination, communication, and team-based care, new measure options for topped-out specialty areas, measures that focus on or address health equity, COVID-19, and the patient voice. Next slide. Thank you. As stated, we seek to move towards more outcome-based measures, which includes patient-reported outcome-based performance measures that utilize PROMs. Patient experience measures aim to improve customer experience that support innovative approaches to improve quality, accessibility, and affordability, and most importantly, empowering patients and clinicians to make decisions about their health care together. This incorporates the patient voice, which is a priority within CMS. For further information on outcome-based measure types, please refer to the CMS MMS Hub. Next slide, please. We aim to reduce the reporting burden for clinicians. You may notice that we have been adding administrative claims which do not require additional action on the behalf of the clinician, but are automatically calculated using claims data. Additionally, implementing digital quality measures, or DQMs, that leverage sources of health information that are captured and can be transmitted electronically and via interoperable systems will assist in the effort. And we continue to improve the digital strategy by using FHIR-based standards to exchange clinical information through application programming interfaces, allowing clinicians to digitally submit quality information one time that can be used in many ways. Accelerating the transition to fully electronic measures, working across CMS to use artificial intelligence to identify quality problems before patients are harmed and intervene accordingly, and developing more APIs for quality measure data submission and interoperability. Alignment across CMS programs. By aligning measures across programs, those clinicians who participate in multiple programs will have decreased burden as they will not have to implement the same measure concept in multiple ways based upon program. Next slide, please. So here are some do's and don'ts for measure submission to the MUC list. Each year we receive and review measure candidates where we provide consistent feedback to combine, revise, etc. We wanted to walk through typical detours to consider when developing a measure so that your measure has a better opportunity to move forward to the MUC list and eventually MIPS implementation. 1, reviewing the composition format, all or none, any or none, etc. A great example of what types of measures we are looking for is Measure 441, IVD Optimal Care. This takes a more comprehensive approach to managing caring for a patient with IVD by assessing that the blood pressure is controlled, tobacco use cessation or non-user, and taking an aspirin or antiplatelet and statin unless contraindicated. What we don't want to see is those 4 components come in as 4 different measures. Next, we don't want submissions that duplicate or are one-offs to existing MIPS quality measures. We really encourage collaboration with the MIPS measure stewards to be inclusive of appropriate clinical settings and patient populations. For example, a measure doesn't contain the inpatient setting, but you feel it applies to this setting. We don't want to see that measure submitted as a separate measure, but rather, we would encourage you to reach out to the measure steward to see if they are open to expanding the clinical settings represented. As measures are submitted, we do look at the burden that they may pose to clinicians or groups, and we would encourage the development of measures that also take that into consideration, especially leveraging the digital tools that were mentioned earlier. And for this one, the last one on this slide is an important aspect. Please evaluate your measure for any unintended consequences. For example, a cost resource use measure that may deprive oncology patients with SOB of palliative oxygen therapy. Next slide. Moving on to more do's and don'ts. First is submitting a measure that only captures an assessment or that the survey was completed. This top one is probably the most common scenario we see. We will not move those forward and will request that you combine into a single measure that emphasizes a robust quality action. However, if you want to measure the assessment rate separately, there are certainly options to develop your measure similarly to MIPS 226, tobacco use, screening and cessation intervention. This one looks at the percentage of patients who were screened for tobacco use. It looks at those patients who are users who receive tobacco use cessation. And then in the third rate combines them to look at all patients to ensure they were both screened and received cessation intervention if identified as a tobacco user. So if this delineation is important, there are opportunities to provide more granular data to the clinicians. Next, as previously mentioned, we are looking for patient-reported outcomes and intermediate outcomes. I believe that is very apparent in many of our CMS resources and that we are seeking these outcome measures. Moving along, measures should align with the guidelines and if not, would not be considered for the MUC list. For measures already in MIPS each year during the maintenance process, the measures should be updated to align with the current guidelines. If a measure remains misaligned and likely produces misleading results, it may be suppressed until the measure is updated. While we do not score these measures, it does place burden on the clinician to collect data that may not contribute to their final MIPS score. We rely on the measure stewards to alert CMS of guideline issues. Moving on to attribution. Attribution is the assignment of the results of a measure to a reporting clinician or group. MIPS in a clinician group focused program, and we want to implement measures that are attributable to the clinician group or virtual group. For example, we have seen measures that look at medication shortage or equipment supply, which does not speak to the care the clinician group is providing. Those types of measures would not be appropriate for the MIPS program as quality measure. Lastly, all components of the measure should consider the evidence. Denominator exception, medical reason should be precisely defined and evidence-based. A broadly defined medical reason, such as any reason documented by a clinician, may create an uneven comparison if some clinicians apply reasons that may not be evidence-based. However, medication specified in the numerator is shown to cause harm to fetuses, and the patient's pregnancy is documented as the reason for not prescribing an indicated medication. This should not negatively affect the clinician's performance, as there was evidence-based support not to prescribe the contraindicated medication. Next slide. All right, moving on to our last slide of the do's and do nots. We ask that you do not submit a measure that is a never event with no variability between clinicians' performance. While we obviously never want to see a fire in the operating room, they occur so infrequently that it is not a meaningful measure. When looking at complications, measure developers should ensure they are trying to close a gap in a given complication or event. They are important measures, but we also have to consider the method in which we score the clinicians and groups. If there are less than a percentage separating the top performer from the bottom, it is hard to say one clinician is doing significantly better. We don't want to see measures assessing the standard of care or just consider a low bar. This relates back to the consideration of how we score within MIPS. If there is little variability or gap, it is hard to differentiate performance among clinicians. Measures should ensure a performance gap exists through testing and investigate opportunities to revise the measure to include a comprehensive and robust quality action. Lastly, as previously discussed, we prefer measures that meet the fully developed definition and are not still in the specification or field testing phase of development. Measures should have the applicable testing completed at the time of submission. Next slide, please. All right, having made through the do's and don'ts, as mentioned, we request that performance is included within your submission. Measure performance and evidence should identify opportunities for improvement. CMS does not intend to implement measures in which evidence identifies high levels of performance with little variation or opportunity for improvement. For example, measures that are considered topped out. Also, when developing measures, we would like you to consider the tools used in a measure. They should be standardized, validated tools that are non-proprietary. Lastly, the measures should be intuitive or show high face validity. This is important as the information can be viewed by patients within Care Compare. Now, I would like to turn it over to Allie to discuss the cost measure considerations.
Thanks so much. So now I will review the considerations for potential cost measures, starting with how a measure fits within the current measure inventory. CMS considers the extent to which a measure furthers the goal of the CMS Meaningful Measures 2.0 framework and the extent to which it's consistent with other measures in the MIPS cost performance category. Measures in the MIPS cost performance category share the following features. They define episodes based on medical codes that determine the patient cohort and identify a clinician-patient relationship for the particular type of care being assessed. They specify what costs are included in the measure. And they apply exclusions to ensure completeness of data and a fairly comparable patient cohort, and use a risk adjustment approach to account for expected differences in clinical and other risk factors that affect cost. Additionally, measures shouldn't be duplicative or redundant with a current cost measure. And CMS prefers measures that have a potential to be used in an existing or future MIPS value pathway as part of assessing the value of care for a defined clinical topic. Next slide, please. Regarding considerations for measure construction, testing, and specifications, CMS also considers the following. Does the submitted measure have complete specifications and the required testing information? Is the measure based on measure specifications that have clinical face validity? And are the specifications consistent with practice standards? Do the measure specifications allow for consistent calculation and reproducibility using Medicare claims data? Does the testing information in the submission demonstrate variation to help distinguish cost performance across individual clinicians? Does the measure have clear ex-ante attribution to clinicians? That is, could a clinician anticipate when their responsibility for a patient begins under the measure? Does the measure include the costs of services that reflect the role of that attributed clinician? Is the construction methodology readily understandable to clinicians? And can the measure be presented in a way that conveys clear information on how clinicians can alter their practice to improve measured performance? Next slide, please. This slide shows specialties with limited episode-based cost measures based on empirical analyses of administrative claims data, specifically for the cost measures that are currently in use in MIPS and also undergoing development. So I'll pause here for a moment to give you a moment to read over the list of specialties with limited episode-based cost measures. And also note that for other specialties that do have episode-based cost measures, it is possible that there are other relevant clinical topics for which interested parties may want to consider developing a cost measure. More information about the existing cost measures is available on the QPP website. And with that, I'll pass the presentation back to Laurel to talk more about the resources available.
Thank you, Ellie. Go ahead and go to the next slide, please. There's a lot of resources available for anyone wanting to submit a candidate measure to the call for measures. The first resource listed here is, of course, our Quality Payment Program Service Center. If you have questions about anything to do with the process. There are resources available on the Quality Payment Program Resource Library. It includes zip files that have all of the documents posted for the call for measures, including fact sheets, and the peer-reviewed journal article template that we reviewed was a requirement in a previous slide. The CMS MMS Hub also has a lot of different information as far as measure development and implementation. A portion of that website includes the pre-rulemaking website, which also has links to those documents stated above on the Quality Payment Program Resource Library. CMS also has a Meaningful Measures Hub. as well as the PDFs and that we just discussed are linked here and will be available once the slides are available. With that, I will turn it back over to Olivia for question and answer time.
Perfect, thank you. And yes, we are now going to start the Q&A portion of today's webinar. So just a quick reminder, there are two ways that you can ask questions. The first is you can ask a question live through the webinar audio. And the way you would do that is just click the raise hand button at the bottom of your screen and we'll unmute your line. You can also go ahead and submit a question through the Q&A box and we will read your question out loud. So we'll start with a couple of questions that we have received already. The first question reads, can we resubmit a measure that has been removed?
Hi, this is Lisa Marie Gomez with CMS. So anytime that a measure, let's say that was submitted through the merit system, and as a result, let's say the measure was not moved forward to the MUC list, which is the measures under consideration list. In that instance, CMS would have outlined the reasons why the measure did not move forward. So if, let's say you want to resubmit the measure again, as long as if you were able to address those items that why the measure did not move forward, if you address those items and resubmit, CMS will then be able to reassess the measure and determine if that measure can move forward. So definitely a measure can be resubmitted. And again, I want to highlight that if, let's say you are a measure developer and your measure was previously rejected, you can definitely reach out to our PIMS team and we can have a meeting with you prior to, let's say you resubmit a measure, so that we can go over any elements or items that you may have questions about. Because again, we're here to provide information and be as useful resource to you in the submission of a measure, because we know developers spend a lot of time and resources in that development. So we definitely want to provide that opportunity. So if you have a measure again that did not move forward, but you would like to resubmit it, you can definitely reach out to us and we can meet with you to discuss your measure and see if it's ready for potential resubmission. Thanks.
Thank you, Lisa Marie. And just one more question. It reads, diabetic foot exams and evaluations are an important measure for podiatry. So it looks like they're just looking for clarification.
Yes. I don't know if it's possible to go to slide, I believe it's 30, go to slide 25, if that's possible. So on slide 25, we outline the different needs and priorities for CMS. And in this instance, you can see here, these are our needs and priorities. It's not to say that, and you can see under the CMS needs and priorities on the left-hand side under specialties, podiatry is an area where we do need more measures. So I can't necessarily say which measure would be approved or not. It actually just depends on the measure, because we look at on an annual basis all of our measures in our program. We also look at our measures in our measure set, our measure specialty set. And so if there are measures that, let's say, could be more robust, that could replace a measure, we would definitely consider that. If there's an area or a measure that isn't captured within our current inventory of measures, we also look at that. So there's definitely not like a one blank answer. It's more we look at our inventory of our measures, and here is specifically an area of priorities and needs where we need more measures in these specialties or these top clinical topic areas. So this gives you a more comprehensive idea in terms of measures that we're looking at for these particular areas. Thank you.
Great, thank you. And as we wait for some more questions to be submitted to the Q&A box, it looks like we do have one person with their hand raised. And Rose, I know that you may have already gotten your question. It looks like you lowered your hand. So I think we can give it another minute or two for folks to submit questions either through the Q&A box, or again, if you do want to ask a question live, please go ahead and click that raise hand button. And we have one more question that just came in. It says, there were several macro grant recipients of $2 million specifically granted for development of quality measures. Are you able to share with us which quality measures have actually been developed as a result of that $2 million grant that was dispersed about 4 years ago?
So this is Lisa Marie with CMS. I can't specifically identify like the list of measures that were developed using those macro grants, but I can say that there were some measures that were submitted for consideration and did move through the process. I don't have like a list off the top of my right now, but we did have measures that were developed by various developers through the macro grants, and we did see those come through, and they were part of the muck list and did go on and were reviewed by our multi-stakeholder group that reviewed measures and provided feedback. So I will say that they did go forward in terms of being reviewed and assessed, but I don't have the list right now, but we did appreciate those submissions.
Thank you, Lisa Marie. And the next question that we received, it says, for the cost measure, how will the cost of pharmaceuticals be treated? Not every oncologist pays the same for the same drugs, and we have little opportunity to use the cost to us when a more costly drug is indicated.
Sure, thanks for the question. I can talk a little bit about, for the existing cost measures, how Part D prescription drugs are, or in some instances, are not included in the measure specifications. So some of the current measures in use in MIPS, as well as the cost measures undergoing development, do include Part D prescription drug costs, but those aren't automatically included in all cost measures. Instead, these are included generally when Part D costs make up a substantial portion of the care, when they could be important to assessing clinician performance, and that assessment might be incomplete without considering Part D. And also, we want to make sure that we're accounting for the fact that not all beneficiaries are enrolled in Part D. So to kind of reiterate, we are including Part D prescription drug costs for some of the episode-based cost measures. And when these are included, we are subgrouping so that episodes with and without Part D enrollment are being considered separately. And also we are using standardized prescription drug costs to help account for some of the variation. So
Great,
I'll pause there,
thank
but
you, Allie. Sorry, go ahead.
I was just going to say I'll pause there, but if there were additional questions on drug costs in the cost measures, please feel free to drop them in the chat.
Yes, and on that note, just a reminder, if you do have a question, like Allie mentioned, go ahead and add any questions through that Q&A box. Or if you'd like to ask a question live, you can raise your hand. It doesn't look like we have any at the moment. We'll just pause for a minute or two so folks can submit questions if you have any. One more question that we just received. It reads, do we have a list of all measures that are in the current MVP program for 2023? Also, do we have any list of measures that are suppressed for 2023?
So this particular question isn't necessarily relative to the presentation, but because we did discuss MVPs, what we can do in the chat, we can provide the link to, I know we did include a link in the presentation, and we'll include that link in the chat that gives you a list of to this zip file that includes all information relative to MVPs. So if we could do that, that'd be great. And then for the list of suppressed measures, again, I know that this is not in relation to this particular presentation, but I know the announcement for today's presentation also listed the suppressed measures. So what we will do is we will provide, I don't know if we readily have a link available, but if we could provide a link, that would be great, to the list of suppressed measures for 2022. For 2023, we have not made any determination right now in terms of what measures will be suppressed for the 2023 performance period. But for the 2022 performance period, we recently outlined the full list of measures that will be suppressed for, again, the 2022 performance period. For 2023, we have not identified any measures that are suppressed. Thanks.
Thank you, Lisa Marie. And again, a quick reminder, if you do have a question, please go ahead and submit that into the Q&A box or raise your hand. We did just get a question that says, where do we find the list of measures that were denied or previously removed?
Hi, this is Colleen from the PIMS team. So there are a couple of places where you can find this information for measures that are removed from MIPS that can be found in the PFS final rule for each year of the program. It'll outline which measures were removed and the rationale. If you're looking at which measures moved forward on the MUC list but did not move forward for implementation, you can currently, that information would be on NQF's website looking at the previous MUC list measures, and then that corresponds also to the PFS final rule for which measures were proposed for inclusion and subsequently finalized.
Thank you, and we'll pause here just for another minute or two. If you do have a question, please go ahead and submit, and we'll give it another minute.
And this is Lisa Marie Gomez with CMS. I know we're receiving a lot of questions that aren't necessarily in relation to today's presentation. So if you have any questions that relate to if you're a current participant in the program in MIPS and you actually report measures, any questions that you may have, please submit those to the Quality Payment Program Service Center, because again, today's presentation is specific to measures for CMS to consider in potential implementation in MIPS. So again, if you have any questions that are not in relation to today's presentation, please submit those to the Quality Payment Program Service Center. If someone in the chat can outline the Quality Payment Program email address and phone number so they can contact if they have questions specifically in relation to actually participating in MIPS and let's say the reporting requirements, that would be great if we could do that in the chat. Thank you so much.
We'll just give it one more minute. If you do have a question, please go ahead and submit that through the Q&A box or raise your hand. We'll give it another minute or so. And we are seeing some questions. So just a reminder, the slide deck and the recording from today's webinar will be posted on the QPP webinar library in about 2 weeks. So for those who have asked for access to the slides or the recording or transcript, those will all be available again on the QPP webinar library. Okay. It looks like we haven't received any additional questions. So Lisa Marie, I will turn it back to you to close us out.
Great, thank you, Olivia. I want to thank everyone for joining today's presentation and having your interest in submitting measures for CMS to consider for the potential implementation in MIPS. Again, we are grateful for all the time and resources that you put into developing measures. Again, thank you, and we hope you have a wonderful day. Thank you so much. Take care.